Right, so good afternoon, everybody. It's a real pleasure to be here at the first Cardiomyopathy UK fully digital conference. My name is Juan Pablo Kaski. I'm a paediatric cardiomyopathy doctor. And I'll be talking to you today about heart muscle disease in children and young people specifically. Now, I would usually start this talk by asking you how many of you have been affected either personally or through a family member or a friend by the different types of cardiomyopathy, but obviously that's not going to be possible today. But I hope that we'll have enough time for questions afterwards, and I really look forward to that interaction at the end of the talk. So what I'll try and do really over the next half an hour or so is give you an overview of cardiomyopathies in children and young people, but also to give you an idea of some of the new advances in the field of cardiomyopathies. We'll start off with a definition. So what is a cardiomyopathy? So it's a long medical word that really just means abnormal heart muscle. So cardio means heart, myopathy means disease of the muscle. So it's a condition that affects the muscle of the heart that can't be explained by other things that could go wrong with the heart. So things like valve disease or congenital heart disease, holes in the heart, that sort of thing. And we define it we classify them according to how they look. So it's almost a description of how the heart looks. This slide is a cartoon of that. So we have hypertrophic cardiomyopathy in the top left of the panel, where you have abnormal thickening of the heart muscle. You have dilated cardiomyopathy, where the heart is enlarged, the walls are thin and don't pump very well. We have arrhythmogenic cardiomyopathies, which can affect both the right and left sides of the heart and can be associated with abnormal heart rhythms or arrhythmias. And there are a number of other cardiomyopathy subtypes that we recognize. And this is how these subtypes look on echo, which is an ultrasound scan of the heart. So again, the top left panel shows the heart on its side, and the big blob of white that you can see is the thickened heart muscle that separates the right and the left pumping chambers. So that's hypertrophic cardiomyopathy, thickened heart muscle. The panel on the top right of the screen shows dilated cardiomyopathy, so an enlarged, baggy heart with actually quite a thin wall that doesn't really pump very well. At the bottom, we have restrictive cardiomyopathy, where the pumping chambers of the heart can be fairly normal looking, but they are very stiff. They don't relax very well, and that leads to a buildup of pressure in the top chambers, the atria, and so they become very, very enlarged. And then the bottom right panel shows an example of arrhythmogenic right ventricular cardiomyopathy. So the left of that picture shows the right ventricle, the right pumping chamber, which is enlarged, doesn't pump very well, and has little ballooned areas around it. So this is how we define and classify the cardiomyopathies, not just in children, but in adults also. But that initial description really is just the beginning of identifying the condition. These are not diagnoses in their own right, but they're just a description of how the heart muscle looks. Once we've made that initial description of the heart muscle, we then go on to try to define it further. So we identify whether we're talking about familial disease, so conditions that run in the family, which are often genetic, and conditions which don't have a genetic basis to them. In terms of how common these conditions are, we know that in adults, the most common of the cardiomyopathies is hypertrophic cardiomyopathy, followed by dilated cardiomyopathy, and the others are a little rarer. In children, it's not dissimilar. We think that possibly dilated cardiomyopathy may be a little bit more common. Hypertrophic cardiomyopathy is the second most common type of cardiomyopathy in children and in young teenagers. But we're really talking about an order of magnitude or more of difference compared to how common these conditions are in adults. So in adults, for hypertrophic cardiomyopathy, this is something that happens in approximately 1 in every 500 people. In some series, there are data to suggest that it's even more common than that. In contrast, in children for the same condition, we're talking about a frequency of approximately 3 per 100,000. So much, much rarer than we see in the adults. And it's the same picture in dilated cardiomyopathy here, the annual incidence of new cases in the UK of dilated cardiomyopathy is less than 1 in every 100,000 per year, particularly affecting in the children in the first year of life, with a second peak towards adolescence. And this is something that we see across all the different cardiomyopathy subtypes in children. There's an early peak in the first year or two of life, and then there's a second peak towards adolescence in terms of when the diagnosis is made. Now, thinking about the cardiomyopathies, there are a number of common features. We know that the condition can be genetic or it can be acquired. We know that the condition can present in very different ways. So in different families, individuals with the same type of cardiomyopathy, so for example, hypertrophic cardiomyopathy, will express that cardiomyopathy in different ways. But even within the same family, different individuals, different members of the same family will express the condition in very different ways. And that's known as incomplete penetrance and variable expression. Those are the medical words for that. And part of that is related to age. It's the reason that some of these cardiomyopathies are much rarer in children than they are in adults. So a lot of these conditions develop, the features of the condition develop over time as children get older. In terms of how we manage these conditions, again, there are some similarities across all of the cardiomyopathy subtypes. So it's important to understand the underlying cause, identify a gene variant if there is one in the family, and that then allows us to screen other individuals in the family, so family screening. It's important to identify and to treat any symptoms that might develop. And it's important also to try to prevent complications developing from the condition. So in all of the cardiomyopathy subtypes, there is a potential risk of developing abnormal heart rhythms, potentially very dangerous abnormal heart rhythms, which in some individuals can result in sudden death, but also other types of complications, things like abnormal rhythms from the top chamber of the heart and stroke and development of heart failure. And this is the same across all different types of cardiomyopathy. But of course, there are differences. And what I'll try and do is just go through some of the specific aspects of some of these different types of cardiomyopathy, particularly as related to the pediatric population, so young individuals. For hypertrophic cardiomyopathy, this is data from a national UK cohort study that we published last year. And we showed that most children diagnosed with hypertrophic cardiomyopathy don't have a secondary cause for their cardiomyopathy. So it's a primary hypertrophic cardiomyopathy. But there are important conditions that can affect not just the heart, but other parts of the body that can also be associated with hypertrophic cardiomyopathy. And we call these malformation syndromes or metabolic diseases. And these are particularly common when we make a diagnosis of hypertrophic cardiomyopathy in very young children, so usually in the first year of life or so. Just like with dilated cardiomyopathy that I showed you before, there is this peak in the first year of life where we make the diagnosis. A proportion of those will have these secondary causes, so things like Noonan syndrome or metabolic disorders. And then there's a fairly even distribution of onset of diagnosis across the whole of the pediatric age group and into the teenage years also. When we think about these so-called secondary causes, there are many, many, many of those. There are very, very long lists, and some of these are just shown here, but they are essentially conditions that often affect not just the heart, but other parts of the body also, and the heart is one aspect of them, often a very important aspect of those conditions. It's a similar story for dilated cardiomyopathy. So again, we divide the causes of dilated cardiomyopathy into familial genetic causes and non-familial causes. And in dilated cardiomyopathy in particular, the non-familial causes are important because it's thought that a significant proportion of cases of dilated cardiomyopathy in children are caused by a viral infection. We call that a myocarditis. But there are other very important genetic causes, again, many of them associated with effects on other parts of the body, not just the heart, and others that are purely an isolated genetic cause that affects the heart on its own. So it's important to look for all of these conditions in anybody where we make a diagnosis of one of the cardiomyopathies. Again, looking at the causes of dilated cardiomyopathy, this is information from a North American registry, and very much like we showed with hypertrophic cardiomyopathy, most children and teenagers with dilated cardiomyopathy have a form of the condition that just affects the heart on its own. Often this is genetic. There are other causes to think about, and I mentioned already myocarditis as viral infection as an important cause of that. But in this study, only 5% of the dilated cardiomyopathies in children were familial, so were conditions that they could identify had run in the family. And most of these were inherited in what we call a dominant way, and I'll explain what that means in just a second. So the information that we have so far suggests that perhaps the cardiomyopathies, particularly dilated cardiomyopathy, may not be familial or genetic in that many children. But actually, I don't think that's the case. I think the problem is that we haven't really been looking for genetic and familial disease, particularly in dilated cardiomyopathy. But as we're starting to look, we're starting to realize that actually, very much like in adults with dilated cardiomyopathy, up to half of the cases of dilated cardiomyopathy have a genetic and then a potentially familial basis. And this is particularly the case in the sort of conditions that we describe as arrhythmogenic dilated cardiomyopathy. So dilated cardiomyopathies that are associated with a risk of developing abnormal heart rhythm. So we can, as we start to look for genetic causes and we start to evaluate family members, we realize that actually these conditions can also present in children and also do have a genetic basis in children. And we were able to show this with a European registry, so collecting information from lots of different countries across Europe, and showing that as we have seen in adult populations, for most of the cardiomyopathies in most age groups, the majority of them have an identifiable genetic cause. So really important to think about genetic disease in cardiomyopathies, even in children. Now, when we think about hypertrophic cardiomyopathy in particular, but also dilated cardiomyopathy, most of the gene changes that we identify are part of this structure called the cardiac sarcomere, which is essentially the building block of the heart muscle. This is these are the proteins that allow the heart to contract and to relax. And we know that in adults, over 60% of patients with hypertrophic cardiomyopathy have mutations or variants in genes that are important for the development of this structure, the cardiac sarcomere. And it's the same in children. So many years ago, we looked at a group of children who were diagnosed with hypertrophic cardiomyopathy below the age of 13, so very young children. We found that actually 2/3 of them had a family history. So very much like in adults, but also over 50% had changes in these genes, the sarcomere protein genes. So very much like in the adult population. And this was the case even in the very youngest children. So even children diagnosed below the age of 5, in most cases, the hypertrophic cardiomyopathy is caused by changes in these sarcomeric genes. And this, of course, has important implications for screening other people in the family, as I'll come on to in a second. We have found something similar in other types of cardiomyopathy. So this is the example of restrictive cardiomyopathy, which is a much rarer form of cardiomyopathy in children. Only a few hundred children identified with this condition in the world. But again, over 1/3 have changes in exactly the same genes, these sarcomere protein genes. And these are all gene changes that are potentially heritable. And we're beginning also now to understand that the arrhythmogenic cardiomyopathies also have a strong genetic basis in children, as they do in adults. And it's a very complicated slide, but this just shows the junction of two cells, and a lot of the genes that are responsible for causing arrhythmogenic cardiomyopathy are genes that play a very key role in the sort of interaction between the heart muscle cells with each other. And we can identify some particular genes that tend to cause arrhythmogenic right ventricular cardiomyopathy, so a condition that affects particularly the right side of the heart, others that more commonly affect the left side of the heart, and others that affect both the left and the right side of the heart. And increasingly, we're identifying that many of these gene changes can also present in young children if you start to look for them. So I mentioned earlier that the way that most of these conditions are inherited, and this applies across the board with all of the cardiomyopathies, is in this autosomal dominant pattern, which effectively means that if somebody has the condition or one of the genes that causes the condition, there's a 50% chance of passing that on to each of their children. And the reason for that is that all of us have 2 copies of every single gene, one that we inherit from our fathers and one that we inherit from our mothers. And so there's a 1 in 2 chance of each one of those genes being passed on. So if one of us has a faulty gene, so in the example in this picture, if the father has a faulty gene, which is depicted by the capital D, then there's a 50% or a 1 in 2 chance that each of their children will inherit that faulty gene. And that's the case whether you're a boy or a girl. So the way that these conditions are often or usually inherited is in such a way that it doesn't really matter whether you're a boy or a girl. There's a 50% chance of inheriting that condition, or at least inheriting the gene that causes the condition. Then there are differences in how that gene is expressed. So in some cases, and really for reasons that we don't fully understand, even though the gene is inherited in this dominant way, 50% way, for some reason the gene is expressed in a different way in boys compared to girls in some cases of these cardiomyopathies. Now, there are other types of inheritance pattern as well that are important for the cardiomyopathies, but this is the most common way in which these conditions are inherited. And so when you draw a family tree, and this is just an example of the first family really to be described with hypertrophic cardiomyopathy back in 1959, individuals colored in black are those who have the condition, who are affected by hypertrophic cardiomyopathy. And so in a dominantly inherited condition, this is the sort of family tree that you see with lots of individuals affected in the family in all of the generations. Now, of course, somebody has to be the first person in the family to have the abnormal gene, so it is possible to have a genetic form of cardiomyopathy that hasn't been inherited from a parent because that abnormal gene developed for the first time in that individual, but then that individual would have a 50% chance of passing that gene change on to each of their own children, so then it becomes a heritable condition. I mentioned earlier on this concept of incomplete penetrance and variable expression, which effectively means that within the same family, individuals carrying the same gene change will express that in different ways. So in this particular example of 31 individuals with this particular gene change that causes hypertrophic cardiomyopathy, 19 had evidence of thickening of their heart muscle on their echo, so they had hypertrophic cardiomyopathy, but 12 didn't have any evidence of a thickened heart muscle. And of those, 7 also had a completely normal ECG. So it's possible to carry the gene change that causes the condition in the family without it necessarily showing all of the features at any given point in time. And this is particularly relevant in children and young teenagers because of this age-related penetrance. The condition can develop over time, even if the inherited gene is present from the very beginning. And so this leads a little bit onto the first of the 3 things that I want to focus on for the rest of the talk, and that's in relation to screening, to family screening. When we think about family screening, actually what we're talking about is 2 things. There's clinical screening, where we see patients in clinic and we perform routine tests, so things like ECGs and echoes, which I'll show you examples of in a little while, but also genetic screening. So if we have identified a gene change in the family that we are confident explains the condition in that family, that then allows us to test other people in the family who may not have any evidence of the condition to see whether they have also inherited that gene change or not. And the main benefit of that is that if a relative doesn't have that gene change, they then don't need to continue to be screened from a clinical basis. They can be discharged from clinical follow-up. And on the other hand, if they have that gene change that's seen in the family, then it's important that they remain under follow-up, because it's possible for the signs of the condition to develop over time. The guidelines at the moment, so the international guidelines, do recommend this form of clinical and genetic screening, cascade screening, really to all first-degree relatives. That's somebody who's directly related to somebody who has the cardiomyopathy. So that would be a child or a sibling or a parent, and that's a universal recommendation that should be performed. At the moment, the guidelines say that this sort of screening should start from the age of 10 or 12, depending on whether you look at the European or the American guidelines, but they currently don't recommend routine clinical or genetic screening for most cardiomyopathies below the age of 10 or 12. And the reason for this is that a number of studies that are really now fairly old have suggested that familial disease is not so common in children, and also that particularly with hypertrophic cardiomyopathy, that in families with this condition, the features of the disease don't tend to develop until the adolescent years, until the teenage years. At least that was what these studies have suggested. And there are there's other information using genetic data to suggest again that these sarcomeric mutations, the sarcomeric gene changes, don't apparently present before the sort of late teenage years. And so this is the basis for these guidelines. But the problem is that, as I've mentioned before, if you don't look for these conditions, you're not going to find them, but they're there. So looking back at some of these studies, this study suggesting that the left ventricular thickening didn't develop until the teenage years, actually very, very few children below the age of 10 were included in this study. And those that were included already had thickened heart muscle. So they already had the condition. So it's just not true that the condition didn't develop until later on. And similarly with the genetic study, there are no children included below the age of 10 in this study. So of course, if you don't look below the age of 10, you're not going to find it. But in our experience, where we have been screening children from birth, really, we have shown that actually in a substantial number of patients, about 10% of families, if you look for evidence of hypertrophic cardiomyopathy, you find it there, and you find it at the very beginning. So nearly 80% of the children that we've screened who we've made the diagnosis of hypertrophic cardiomyopathy because of a family history, in nearly 80%, we make that diagnosis below the age of 12, usually at an average of 10 years of age, but including lots and lots of children who are much, much younger than that, including in the first year of life. So if we had just followed the current guidelines, we'd have missed a significant proportion of these children who clearly have evidence of the condition. And importantly, having the condition means that they're at risk of developing symptoms, and identifying them early meant that we were able to alter their treatment in over a third of those patients. So really important to make the diagnosis early. And there is similar data from a group in Canada that was published a few months after we published ours. And in those in whom we don't make the diagnosis at the very first visit, which actually is a minority of patients, in over 50% of those, the condition then does develop, and often that develops within the period of childhood and the teenage years. So the current guidelines that don't recommend routine screening in childhood, I think are not necessarily the right approach, and certainly not the approach that we have taken. Now, of course, what we don't want to do is to cause more problems. And one of the worries that people have about performing screening, clinical or genetic screening, is that it might potentially introduce a degree of anxiety of coming to hospital, potentially being told they have a condition that, or at least carry a gene that may not cause any problems to them now, but might cause problems in the future. But we've looked very carefully at this also, and with the right approach, so having a good multidisciplinary team that includes genetic counselors and clinical psychologists, actually the prevalence, the frequency of anxiety in the children that we're screening, even those in whom we find that they carry the gene, even if their tests are normal, the anxiety scores are exactly the same as the general population. So we don't seem to be causing any harm by screening them early. So these are my screening recommendations. This is what we do in our centre, and I appreciate that this may not be what's offered in other centres around the UK or around the world indeed, but we would certainly want to screen anybody who has one of those conditions that can affect the heart as well as other parts of the body. And we would screen anybody who is a first-degree relative, so directly related to somebody who has a cardiomyopathy. We start from birth, and how frequently, how often we do the screening really depends on the child's age, depends on what the family history looks like, and it depends also on the diagnosis. But essentially, we see them relatively infrequently, so every 2 or 3 years for the first few years of life, and then every year or so from the age of 8 onwards. And then sometimes, depending on the family history, we might see them even as frequently as twice a year during the teenage years, but certainly once a year during that period. These are the tests that we do. So we do ECGs and echoes and a number of other tests that I'll show you very quick examples of in a second, but also we consider genetic testing as part of our screening process. And we do this in our own centre, which is a specialist centre for inherited cardiac conditions. And this is in line with NHS England recommendations that anybody who is potentially at risk of developing an inherited condition, of which the cardiomyopathies are an example, should at least be seen at least once in a specialist inherited centre. One of the reasons we do this, and one of the aspects that are really important for everybody when we think about cardiomyopathies, is this issue of risk of abnormal heart rhythms and risk of sudden cardiac death. And we know that the majority of children with cardiomyopathies, and here the data really are particularly on hypertrophic cardiomyopathy because it's the one that we've studied the most. But the majority of children with hypertrophic cardiomyopathy don't have a particularly high risk of developing abnormal heart rhythms. But it is important to identify who those individuals are. And in adults, we have very good risk models that can help us to estimate the risk of an abnormal heart rhythm at 5 years, but we can't really use those in children because they've not been tested in children. So what we've tried to do over the last couple of years is develop an international consortium of hypertrophic cardiomyopathy in children, where we've put together a number of expert centres from around the world, and we use this to develop a paediatric specific, so a risk model that can help to identify risk in children with hypertrophic cardiomyopathy. And we've shown that this model works well. So really for the first time now, we have a tool that allows us to give children a slightly more individualized estimate of what their risk of developing an abnormal heart rhythm might be. And this helps us to decide who would benefit from implantation of a defibrillator, for example. And we're starting now slowly also to identify the factors that increase risk in other types of cardiomyopathy also, so particularly arrhythmogenic cardiomyopathy, where there are some features that are specific to children with these conditions that are slightly different to what you see in adults. And then finally, just talking about treatment, as I mentioned before, the way that we treat these conditions really has several aspects to it. So we want to identify symptoms if they're there, work out why they're happening, and then treat them. And that's usually with medication. We want to identify children who are at a higher risk of developing complications and try to prevent those. We have to think about the psychological impact of these conditions, not just to the child, but to everybody around that child. And so when we manage a cardiomyopathy and when you come to our clinic, it's not just the child or the patient who's in front of us that we think about. We have to think about the family as a whole. And this is something that's the case across all the different cardiomyopathy subtypes. And in order to do that, you need to have an integrated service that includes specialists and experts from all fields, not just in cardiology, but always having the child and the family at the center of that. So these are the tests that we do. So this is the ECGs, which gives you a tracing of the heart rhythm. This is an echo scan. So this is the ultrasound scan of the heart, which allows us to look at the structure of the heart, allows us to measure the thickness of the wall of the heart, allows us to measure the pumping function of the heart. This is an MRI machine. So this is an extra test that increasingly we're able to do because of the techniques that we now have, we're able to perform these tests in around 10 or 15 minutes compared to about an hour, which was the case not so long ago. And again, this gives us beautiful pictures of the heart, but also gives us a bit of information that we don't get on the echo, and that is that it allows us to look at the heart muscle itself and identify, for example, whether there are any areas of scar tissue or swelling around the muscle of the heart. We don't just look at the structure of the heart, but we actually try to define how the heart muscle looks in itself, and we can do that both with echo and with MRI. We also do exercise tests. We can do Holter monitoring, so send children away with 24-hour tapes or week-long tapes. There are new devices that are just stickers that you can stick at the front of the chest, and it just measures and monitors the heart rhythm for up to 2 weeks. The reason we see children in these clinics is a combination. So it's either family screening because somebody else in the family has the condition, or they've presented with symptoms. And when that happens, it's usually symptoms of breathlessness or chest pain or feeling your heart beating very quickly or feeling dizzy or even fainting. And in the younger children, in the babies, it's excessive sweating, poor feeding, not being able to gain weight as you'd expect them to. And sometimes we pick these conditions up completely incidentally. Someone will identify a murmur for whatever reason, or a child will have an ECG and they'll pick up some abnormalities that then lead to the diagnosis. This is a very complicated slide, but this is effectively a summary of the way that we treat, in this case, hypertrophic cardiomyopathy, but it's actually very similar across all the different types of cardiomyopathy. We start off from what the patient is telling us, what symptoms they have, and why those symptoms have developed. And then we treat, usually with medication, but in some cases, there's a need for surgical treatment, so operations, for example, to relieve some of the narrowing of the heart in hypertrophic cardiomyopathy, or implanting devices such as pacemakers or defibrillators if we think that the risk of an abnormal rhythm is a little bit higher. The way that we treat symptoms really hasn't changed over the last 20 or 30 years. We still use the same medicines that have been in use since the 1970s, so beta blockers, calcium channel blockers, disopyramide, diuretics for children who have dilated cardiomyopathy and symptoms of what we call heart failure. We also have to think about lifestyle issues. So in some cases, we need to think about whether very competitive or strenuous activities are wise. We have to think about the impact that the condition can have on school life, but also on work for the parents. Things like tattoos and body piercings in some teenagers may not be the best idea, particularly if they have devices such as the defibrillator. We have to think about things like alcohol, pregnancy. So this is all part of the holistic management for these conditions. And just in the last minute, I just want to finish off by saying that up until now, really, our treatment of these conditions has been, say, empirical. So we identify symptoms and we try and treat those. We think about potential complications and we try to prevent them. But wouldn't it be nice to develop treatments that actually stop the progression of the condition, or even stop the conditioning from developing the condition from developing in the first place? And there are some examples of this in cardiomyopathies in the pediatric population, in children and teenagers. So, for example, this is a very rare metabolic condition called Pompei's disease. It's one of those conditions that affects other parts of the body too, but it's caused by a deficiency in a particular enzyme, and there is now an enzyme replacement treatment that we can now see causes the heart muscle, which is very, very thick often at the very beginning, to actually thin over time. And there are new treatments coming on for some of these other conditions, Noonan syndrome, some of the malformation syndromes, that again appear to slow the progression of the wall thickening. And as I said, up until now, the treatment has been related to symptoms, related to preventing complications, but increasingly now, even for the more common types of cardiomyopathies, there are treatments coming online that could potentially affect the development or the progression of the condition. So there's a particular drug called Mavacamten that many of you will have heard of. It's a drug that has been around for a couple of years, but just very recently, in the last few weeks, a major study was published showing that in adults with hypertrophic cardiomyopathy with symptoms related to narrowing of the outflow tract, to obstruction, this drug improves symptoms, reduces obstruction, and reduces some of the other blood markers that we use that tell us about the sort of severity of the condition. So this is a drug that particularly targets the underlying genetic effects in hypertrophic cardiomyopathy. And what's really exciting for me as a pediatric cardiologist is that in the animal models where they were trying this drug out, it also appeared to prevent left ventricular thickening from developing in the first place. So I think there's a lot of hope on the horizon for the treatment of cardiomyopathies. And I think particularly in young children and in young teenagers, there is the potential over the next few years for brand new ways of thinking about the treatment of these conditions. So I'm going to stop there, and hopefully there's a little bit of time for questions if there are any. But thank you very much for listening.
Hi, Juan Pablo, can you hear me?
And yes.
Hi, it's Christy from Cardiomyopathy UK. We've got a couple of questions that have come through, and certainly if anyone wants to submit any last-minute questions, we can also cover those. The first question is this. I've had myocarditis. How often should I be seen by my GP and or cardiologist for a review of medication and an echocardiogram? I was admitted to hospital in February 2010 with heart failure caused by a virus. My last echocardiogram was 2 years ago.
So thank you, Chris. So that's a very, very good question. And actually, it's one for which our understanding, our advice is changing all the time. So many years ago, we used to think that if somebody developed myocarditis, there was 30% chance that everything would improve by itself and that there would be no need for further follow-up, a 30% chance that things would sort of stabilize, and a 30% chance that things would progressively get worse. Actually, what we realize is that in many cases, the condition can get better with treatment, but that ongoing follow-up is essential because this can sometimes be the sort of the very first signs of an underlying cardiomyopathy. So not just the virus itself affecting the heart muscle, but sometimes the virus can be what unmasks an underlying cardiomyopathy. So our current advice is that anybody who's had a myocarditis that has affected the pumping function of the heart should remain under follow-up. And certainly if you're on medication, then it's extremely important that you see your cardiologist to make sure that there aren't any changes required to that medication. In terms of how frequently that would be, it depends on how stable things have been. It depends a little bit on your age also. But I would have thought that a review every 1 to 2 years would be appropriate for most people.
Thanks, Juan Pablo. The next question is, could we have an explanation of Noonan syndrome, please?
Of course. So Noonan syndrome is one of those conditions that affects not just the heart, but affects many other parts of the body. It's a genetic condition, and it's a genetic condition that's caused by changes in genes that are present in every cell of the body, which is why when somebody has a spelling mistake in one of those genes, it can affect all different parts of the body. So often children with Noonan syndrome can be a little bit shorter than others. They sometimes have very characteristic facial features. And they very frequently develop heart disease, and that is a combination of one of two things. So really up to sort of 60 or 70% of children with Noonan syndrome can develop problems with the valves in the heart, particularly the lung artery valve, the pulmonary valve, and they can develop a narrowing of that valve. And about 20 or 30% of children with Noonan syndrome or related conditions can develop hypertrophic cardiomyopathy, although the frequency of that depends on which gene has caused Noonan syndrome. There are many genes that can cause it. But it's a condition that often presents in the first year of life. But a lot of the features of Noonan syndrome can be very mild and very subtle. as children grow up and develop. And so actually it's not unusual for us to make a diagnosis of Noonan syndrome in children with hypertrophic cardiomyopathy who are thought to just have an isolated hypertrophic cardiomyopathy, but in fact have Noonan syndrome with very mild obvious features. It's a condition that, because it can affect other parts of the body as well, it's really important that anybody who has Noonan syndrome should be seen by a geneticist to explore whether other parts of the body are affected, and that can include eyesight and hearing. Sometimes children with this condition can develop kidney problems. So it's a condition that requires input from lots and lots of different specialties.
Thanks very much, Juan Pablo. The next one is, will people start prescribing, sorry if I pronounce this incorrectly, Mavacamten to children?
So that's an excellent question. So at the moment, there's a lot of excitement about Mavacamten, quite rightly, because it's a brand new class of drug, and certainly the trials have been extremely promising. It's still very early days. None of the trials have included any children. So we have no information, no clinical information on whether it is a safe drug to give to children, and we have no information on whether it is an effective drug in children. So I think at the moment it's very unlikely that we will be prescribing Mavacamten on a routine basis to any children. I think what we really need is to be able to carry out clinical trials on children with hypertrophic cardiomyopathy to make sure that it's a safe drug to give, and also to check that it has a similar effect in children as it has in adults. The results are very, very promising, and so I suspect that in the course of time, this will be another drug that will be available to us as paediatric cardiologists, but I don't think we're quite there yet.
Thank you very much. We've got time for one more question. Any questions that haven't been answered, we will strive to answer during our Q&A sessions at 3:15 this afternoon. But if you don't mind one more, Juan Pablo, the question is, how often can the genetic reason behind a diagnosis of cardiomyopathy not be identified? And is the gene identification necessary?
So that's again a fantastic question. So it depends on the type of cardiomyopathy. So for example, in hypertrophic cardiomyopathy, in children, we find a genetic cause in approximately 60 or 70% of cases. In dilated cardiomyopathy at the moment, we have a maybe 30% chance of finding a genetic cause in children with dilated cardiomyopathy. So it depends a little bit on the type of cardiomyopathy. That's partly because we haven't really understood the genetic basis of some of these cardiomyopathies completely yet. But for in most cases, there's a good chance. Now, in terms of how important it is, so I would argue that it's very important to try to identify a genetic cause because in some cases it can affect the treatment that we give. So particularly with some of the genes that cause dilated cardiomyopathy, we know that some of those genes are particularly associated with a higher risk of abnormal rhythms. And so we might have a lower threshold for thinking about defibrillators, for instance, if we identify that particular gene change. But also for the family, if we identify the gene in the family, it means we have a much more definitive way of testing the relatives and other people in the family, and potentially discharging up to 50% of those children who would otherwise have to keep coming back for ECGs and echoes and other tests. But if we don't identify a gene, it's not the end of the world. So in terms of how we treat most of these conditions, actually the genetic testing doesn't make a huge difference. So most of the time, the importance of genetic testing is for the rest of the family, not so much for the patient that we have in front of us.
Excellent. Thanks for that. I will leave you to wrap things up. Thank you very much for your talk, Dr. Kaski.
Fantastic. No, it's a real pleasure, and I hope I hope that this format has worked. It's certainly been an honour for me to be a part of this. So thank you very much, and I'll see you all at the Q&A session later on.